Welcome to Fertilish, the podcast where we get real about fertility, infertility, and everything in between. I'm Laura.
And I'm Brandis. And whether you're knee-deep in treatments, just starting to ask questions, or somewhere in the ish of it all, you're in the right place.
Here we ditch the stigma, break down the science, and have candid conversations about the messy, emotional, and sometimes hilarious journey to growing a family and preserving your fertility.
So grab your coffee, your meds, or just your curiosity, and let's get into it. All right, so we are back for another episode of Fertilish, and today we are talking all about a low AMH and fertility.
Yes, and I wanted to recognize a special listener who has written to us very heartfelt appreciation and just kind of gone into her experience as being mid-20s and getting a very surprising diagnosis of diminished ovarian reserve. And so we've connected with her, and she wanted us to do an episode about DOR. And so we are dedicating this episode to her and all of our other listeners who have experienced either low AMH or diminished ovarian reserve.
Yeah, see, it goes to show that we do listen to you and read your messages.
That's right.
And then AMH is anti-Müllerian hormone, and we'll go over what that means for those that don't know. And then DOR, like Laura said, is diminished ovarian reserve. But I think, even to just get started with this episode, it's important to know what AMH actually is and what kind of we're measuring. So AMH is a blood test. And so kind of going back to the menstrual cycle, think of it as you have a vault of eggs that you're born with. You had them before you were ever born. You had them when you were when your mom was pregnant with you. You actually lose the most eggs you will ever have between when you're a 20-week-old baby and the time you're born. And then when you're born, we start losing eggs every month. So we have a vault of eggs. Every month, a group of eggs comes out of the vault into each ovary, into both ovaries. One will grow to become dominant and mature and will ovulate. The rest of those eggs will die off, and we lose. So we're not just losing one egg a month, we're losing groups of them every month. And this is happening before puberty. This happens when you're pregnant. This happens when you're breastfeeding. This happens when you're on birth control. So there's no way to stop this. Every month, no matter what, even before you're born, you are losing eggs, which is unfair.
And fun fact, an egg is the largest cell in the human body.
Isn't that so crazy?
I just saw that written out the other day, and I knew it, but I never saw it written out that way. And so I thought that was so interesting. I was like, oh, wow, yeah, that's crazy.
And it's so cool, even to think about, because when I had eggs retrieved, I went back to the lab after to see what they looked like, because they were my own. I thought it was so cool. And yeah, you can see them with your bare eye in the dish, and that is just the craziest thing.
Yeah, and I think that it said it was the only type of cell that was recognizable with the human eye.
Yeah, which is cool. That is a fun fact. And I don't think a lot of people know that you could see it with your actual eye without a microscope. So that's crazy.
It is.
So what AMH is actually measuring is so I guess back up a little bit. When you're releasing eggs every month from that vault into your ovaries, the vault of eggs you have, so the more eggs you have left, the more eggs you'll release every month. The less eggs you have left, that vault kind of gets a little more stingy, so the less it will release every month. Of those eggs that are released, they have little cells around them called granulosa cells, and those cells produce AMH. And that gives us an idea of how many eggs we can expect to come out of the vault every month. So the higher it is, the more eggs you have left. The lower it is, the less eggs you have left. Now, that's important for IVF because we are limited to the amount of eggs we can get per month. We actually have no way of getting into that vault, which is why freezing your eggs doesn't cause menopause, because we're only getting the eggs that you would have otherwise lost that month. So that's kind of what AMH was measuring. It is not a predictor of fertility, which we'll get into, and it's not a predictor of age or of egg quality. It also, you can have a good ovarian reserve now, and in a year, it could be drastically dropped. And so it doesn't tell us how fast that number is going to go down. It only gives us a picture of right now, which is important. And we didn't learn a whole lot about AMH in school. And as a female, even going for a physical, that's not something, it's not a recommendation, but it's not something that's measured yearly. Did you know what it was before you
No.
were a fertility patient?
Well, I mean, I knew what it was when I went through nursing school, but I never, had it checked, never thought about it, never, it just didn't apply to me until I started trying to, have a baby and have a fertility workup. And so I got my AMH checked, and then it was lower than what, it should have been. And then I was like, okay, what is this, how is this going to affect us? And then I've had it obviously checked a few times since then. And surprisingly, rose quite a bit the last time I had it checked. And I was like, what in the world? How did that even happen? So, important to note, it can fluctuate even, within one person from month to month, or, you're not having it checked each month, but it can fluctuate, from time to time, up or down.
Yeah. So, it can fluctuate by 30% up or down each month. One month you may release 17 eggs, the next month 20, the next month 15. So it can vary, and that's why we only typically check it yearly. But yeah, I've said this, it's not in current guidelines to check this in people, and the reason is because it's not a predictor of fertility. So let's say my AMH is 1, and another 30-year-old's AMH is 3. No matter if somebody has 100 eggs left and the other person has 200,000 eggs left, no matter what, you're both still going to ovulate an egg, and you'll have the same age-related chances of getting pregnant as somebody in your same age group, because you're still ovulating, you just have less eggs left. And so the chances of getting pregnant or fecundability each month, which is what fecundability is, are the same depending on your age group. So that's why they don't recommend testing it every month. However, I'm a big advocate for testing it yearly in everybody with the correct counseling, because it gives us a picture or a snapshot of what your fertility looks like right now. So let's say you have a 21-year-old that, goes in and their AMH is 1. That is low for a 20-year-old or a 21-year-old. And so they may say, look, I don't know how fast this is going to go down, if it'll continue to go down at what rate, but it's low. So if, you're not considering starting a family anytime soon, you may want to think about egg freezing. And now that 21-year-old isn't 27 or 30 trying to start a family with no eggs. Yeah. And so you can't make decisions off of data you don't know. And I think it's a huge disservice that we don't check this in people.
Yeah. And I actually had a conversation, 6 months or so ago with an OBGYN who was like, oh, I think that's a terrible idea. And she went on to tell me that she felt, this is not someone that worked at CNY, sorry.
I'm all who?
Just kidding. She was like, I think that's a terrible idea, and here's why. Because I don't want to create false, or not false, but, unwarranted, unnecessary fear in people if their AMH is not in the normal range or whatever. And I thought, why? Okay, before you're diagnosed with diabetes, we're checking, blood markers to see like where are you within range. And then if it's pre-diabetic, we're making a treatment plan to be able to treat.
That's
you
a
haven't
great
been diagnosed
point.
You haven't been diagnosed with diabetes yet.
So why are we scaring them?
That's right. That's right. So I did, use that analogy with her, and she was like, well, okay, you gave me something to think about. And I was like, oh, good. I'm glad we could have this healthy debate today. But it's not that I know more than her, but it was just like, okay, like, just hear me out from this perspective. And I understand from her perspective when she's seeing patients in the clinic, if they haven't even begin, like thinking about trying to conceive, she doesn't want to cause hysteria, but also how much worse is it going to be if they get to the place where they are trying to conceive and now there's complications that they could have had more options on the front end. And so I appreciated the dialogue, and her being willing to like think about it from this perspective, from the perspective of like, not that I'm the specialist, but the clinical, the specialty clinic perspective. And so, yeah, I think that may be why it's not, checked sometimes, is kind of what she said. But we would encourage, people to advocate for themselves and be like, hey, can you check my AMH, please?
Yeah. Which, I think.
And then talk to me about what it means.
Yeah.
For me.
Or, if you don't have an OBGYN that, they should be well versed, but doesn't feel comfortable counseling you, schedule an appointment with us.
Absolutely. Yeah.
We don't need a referral. You can just pay the consult fee. You don't need to even do treatment.
Right.
I want to check my AMH and talk about my fertility.
That's right.
Cool. I love those visits. But I think that's such, I've heard that too about, it doesn't predict fertility, and it doesn't mean you're not going to get pregnant. It doesn't tell you quality of your eggs. So
That's
why
right.
are we going to induce this unnecessary havoc in people? And I would get it if there was nothing we could do. But now, with egg freezing, even, let's say somebody is 30 and they are married or not married, but they are with somebody that they want to have kids with, and I'm going to get further in my job and establish that first before I have kids, or, they're not ready. They may have an AMH checked and say, oof, my AMH is really low or low for my age, and we want 3 kids. Mm-hmm. That may not be an option if I wait. And so, they may decide to start a family earlier or freeze embryos, so that way they can just do transfers and not have to worry as much about a biological clock. And obviously there's no guarantee with IVF, but we're taking away that decision making from people by not checking it, and I think that's my view on it. So that's my view on AMH, first off.
I 100% agree. I completely agree. And I think that patients who have had their AMH checked after they wanted to start trying to conceive probably would agree with you as well, like especially if it's been on the lower side. But on that same, like on that flip side of the coin, you mentioned like if you're 20 years old and you have an AMH of 1 and that's low, like I think it's healthy to know like what that means for you, because if you are 45 years old and you have an AMH of 1, like we're gonna be like, whoo, that's wonderful.
Yeah.
Like, great.
Yeah.
So it's different for, each person. But just because you have a low AMH, you could have a 0.1 AMH and still have a healthy live birth.
Yeah, and get pregnant and
Yeah, and we do have patients that have super low AMHs all the time that, are sharing with us their beautiful pictures of their babies. So, it's a piece of the puzzle that helps us to be able to formulate a plan to move forward with your goals in mind.
Yes, and you bring up that point about we have plenty of people that have a low AMH or a diminished ovarian reserve that have been denied treatment at other places. So kind of background, there is something called SART that fertility clinics report to. And most clinics will not take you if your AMH is less than 0.3, because these patients, even if they're younger, they're not accepting them because each cycle where you don't get pregnant counts against the clinic. So to put it in perspective, let's even just say we're working on banking embryos, and we know this patient with a diminished ovarian reserve is going to require multiple cycles. If that patient does an egg retrieval and then goes forward to another egg retrieval, that first cycle counts as a hit against a fertility clinic or a ding because that patient didn't get pregnant, even though there was no transfers.
Yeah.
We also know that diminished ovarian reserve patients will have more canceled cycles for no response. And again, even though there were no embryos made, it counts as a not pregnant cycle. And so in order to keep stats up, these types of patients aren't accepted at most places, and at CNY we do accept these patients, because it doesn't mean no hope. It doesn't mean you're not going to get pregnant. Age is still the number one predictor of fertility and IVF success. But it's important to move forward with a lower AMH, knowing, hey, this may take multiple cycles, and be prepared for that with realistic expectations up front. And if you know that and that's worth it to you, it's not hopeless, especially, based on age.
Yeah, I mean, and that there's that whole reason is the reason, that and many other reasons is the reason why CNY really stands out from a lot of other fertility clinics, is because unfortunately we've kind of gotten into a habit in this fertility space, at least in this country, where if patients don't fit into this box, we're unable to help them. And CNY really believes in giving everyone a chance to have the baby that they dream of, or the family that they dream of, or however you want to word that, regardless of whether they're an outlier of this box or not. Yeah. And so that includes like no age restrictions for using your own eggs. Even if our providers say, hey, we would recommend, you contemplate using donor eggs. We have some patients that say, like, don't say that word to me. I'm not even in a space where I can even hear you say that word. Put that in my chart. Like, don't say that. We have some patients that say, like, I would like to try a cycle or two of my own eggs first. And you absolutely have the autonomy to do that here at CNY. But some other fertility clinics, it's because of those success rates.
Yeah.
As to why they're not willing to let you do that. And it's because they want, they're not willing to take the risk of you not having a successful pregnancy. Yeah. And so they only want you to fit into this box, which is really unfortunate because, and this is kind of like my little thing that I say, because how successful are you if you're only worried about your success rates versus the success of your patients? So, there's no greatness without risk. And so I think that's something that's really special about CNY. But BMI is another thing. That's another factor that that some clinics are not willing to, veer outside of these parameters. And that's unfortunate because there are healthy and safe ways to do egg retrievals for people of a variety of different BMIs. So I just don't believe in that being an excuse. But anyway.
Yeah. Well, and, you brought up a good point, is I get a lot of consults where people will ask, hey, CNY, I looked on the SART website or your website, and you guys have lower success rates than
the national
this
average.
fertility clinic or this one. And that is why, is because we take patients that don't fit in, certain guidelines, because we do believe everyone deserves a chance. And
100%.
So again, that's a big reason why.
Well, not only that, like, we're allowing people to transfer, if they're wanting to transfer, aneuploid embryos, so embryos that don't have the greatest chance of achieving a live birth, that's the success is achieving a live birth, or even people to be able to bring their embryos to CNY, which I know we've talked about on this on previous episodes, but for compassionate transfers, they are not looking to have any more children, so Therefore, the goal is to not have this be a successful transfer. But that is the way that they're choosing to move forward with the embryos that they do have frozen. And so we allow them to do that because we really believe in like patient autonomy. And that hurts our success rates, but it doesn't hurt the success of our company in our eyes, because that patient had success in what their goal was, which was to transfer their embryo in a compassionate transfer.
Yeah, and so I think, it is really cool that we do offer these patients a chance. And actually, I'm going to differentiate here. We specifically right now are talking about a lower AMH or a diminished ovarian reserve. We're not talking about this on the severe level. So you're in menopause. That is different. So once you run out of eggs, cycles will stop. So if you have a diminished ovarian reserve or a low AMH, you can even start having irregular cycles. That's fine. Menopause is where you haven't had cycles for 1 full year. A true zero AMH is less than 0.03. FSH levels are follicle stimulating levels. Follicle stimulating hormone levels are usually really high in these patients. So that tells me your brain is trying really hard to grow an egg and nothing's happening, which is important because we are using FSH and medication to grow your eggs. And so if your levels are already high and you're not having cycles, nothing's growing, you aren't getting a period.
It's probably not going to work to add medicine.
To be honest, it's this likely will not work, but we're talking about a low AMH where you're still having cycles, even if they're irregular. And actually, that's a clinical sign to know if you have a low AMH is if you've had, normal cycles and they start shortening, or you start having, luteal phase defects where the second half of that cycle is like 10 days or less after ovulation. That may signal to me, hey, your AMH may be going down, your ovarian reserve. Let's check an AMH. Also important to check your TSH and prolactin as well to rule out other issues. But that's a clinical sign that your AMH or your ovarian reserve is declining. There are some things that can affect AMH and those results. One of those things being birth control. So birth control works by, kind of suppressing FSH from coming down from the brain. It can suppress follicles release. It does not cause a diminished ovarian reserve. It does not cause infertility, but because you are suppressing ovulation, it is, suppressing FSH, AMH. And so if somebody comes for just an AMH check and they've been on birth control for 10 years or a prolonged amount of time and their AMH comes back normal for their age, great. If it comes back lower and they're concerned, I may say, if it's feasible, get off birth control for 3 months. We'll check it again. And sometimes that number does go up. So that's important to know. And then, I think we haven't talked about yet what causes a low AMH. And I think that's one of the most frustrating things is, figuring out what caused it.
Yeah. And there's so many different variables. I think it's hard to pinpoint for any one individual what caused your specific low AMH. Is it, do you have extremely low vitamin D levels? What is it that's caused it? And is there an additional diagnosis that goes with that?
Yeah. People with higher BMIs can have lower AMH levels, and then we have seen that when they lose weight, these levels go up. It's frustrating because 85 to 90% of the time, the reason is idiopathic, meaning that we don't know what caused it, which is probably the most frustrating diagnosis is we don't know. It can be multifactorial. So, maybe that's the hand you were dealt. You were born with fewer eggs, and that's just how it went. Genetics is a big player. So, did your mom, your aunt, your sister go into menopause early? If they did, super important that we're checking your ovarian reserve. Things you were exposed to before birth. So was your mom exposed to things when she was pregnant with you that were totally out of your control? And is that what caused it? Another thing that is important to do is, let me back up. So things that you were born with or exposed to before birth. We talked about in episodes prior, marijuana, cigarette smoking, obviously chemotherapy. So modifiable, lifestyle factors.
Environmental toxins.
Yeah, like BPAs that we've talked about, endocrine disruptors, ovarian surgery. Have you had a cyst removed and extra tissue was removed? Endometriosis surgeries, which we've talked about before. If you're having an endometrioma removed, that can cause a diminished ovarian reserve. So there are a lot of things that can contribute to that, to a lower AMH.
Yeah, and it's hard to, like, you could say, like, oh, well, yeah, I wore perfume and my mom smoked in the house growing up. Like, well, which one is it? Or is it something completely unrelated? Like, it's hard to know, like, is it a culmination of all of these things? Is it one thing? Like, I mean, it's not something that you can pinpoint.
Yeah. So if you do get this diagnosis, you're younger and you have a lower AMH than what we would expect, it is important to have a proper workup. So a lot of this is blood work. One of these things being a karyotype. So that's just, we've talked about this before, a picture of your chromosomes. Does that look normal? We want to check for Turner syndrome, which is you're missing part of an X chromosome, and Fragile X. And Fragile X is super important to catch if you do have a diminished ovarian reserve, and that's something we suspect, because it can expand. So it's important to know the type, or I guess how big the expansion is. Can you pass this on to a daughter, who can have a diminished ovarian reserve and go into menopause sooner? Passing it on to sons can also be devastating. It can cause mental retardation syndrome. And so genetic screening, especially if you have a low AMH that we don't really know why, is super important to figure out. So if you're at a fertility clinic, or you're our patient, or whatever, if you're at a younger age and you have a diminished ovarian reserve, make sure that your provider has not just said, okay, yep, it's just lower. Make sure that they're doing, a workup as to why, not just kind of saying, oh, yep, it's just low. Like, make sure somebody's looking into it.
Right. Yeah. And what is low? Like, for you, like, what should it be? It's good to have an understanding of, like, what the range is that's normal for your particular demographic, and just all the nuances that, understanding the why. Back to that, like, understanding the why.
Yeah. Well, that goes back to proper counseling. Obviously, you can order your own lab tests through like LabCorp and Quest, I think. So you can do that. Just make sure you have somebody, or an appointment with somebody that can actually go through what that means with you. That's super important. Like, if you go check and your AMH is 5 and you're thinking that's on a scale of 100, it's like, oh my God, I have no eggs left.
Yeah.
And a 5 is actually high. So
right.
Yeah, know what the range is, and make sure you have somebody that can counsel you properly on what that number means.
And could potentially mean a marker of something else, like, whether it's, elevated abnormally or abnormally low.
Yeah, and if it is low, another thing we check for too is autoimmune issues. Do you have antibodies that can attack ovarian cells or eggs? We look at thyroid. We do a full thyroid panel. So a full workup and proper counseling is important. As far as IVF outcomes with a lower AMH, there are a lot of studies that have showed that patients with low AMHs or low ovarian reserves can achieve outcomes similar to their age-matched peers over multiple cycles. So even though you may need more cycles then your friend who's the same age as you but has a higher AMH, you guys can have the same success outcomes. You may just need more cycles to get there. And that's why I say, you know, having those realistic expectations up front, that it's not impossible. You just may need 3 cycles when your friend needed 1. And again, that's dependent on your goals too, how big of a family you want, what we're
Right.
banking for.
Yeah, absolutely.
So again, age is the number one factor of success, even with a lower AMH. And as a patient, you should go into that knowing and considering your age-related success rate when making the decision to pursue IVF with your own eggs. Now, financially, you may say, hey, I don't have the money to do 3 cycles. I'm just going to jump to donor egg. And that's fine. But, you know, make sure you're having that conversation with your provider of, hey, this is my age. These are the amount of kids I want. How many cycles do you think I'm going to need? And do you think it's realistic? And I think that's a good conversation to have at your consult.
Absolutely, because you know, there's factors that you may not have thought of that that they could bring to your attention, and then ultimately it would still be your decision whether you wanted to move on to donor eggs. But it's just good to have a comprehensive conversation.
Well, yeah, and the biggest reason people actually stop doing IVF is emotional distress. They're burnt out, and I think that can be worse if you're not prepared for that beforehand. That, hey, this isn't going to be a 1-cycle treatment.
100%. I was never prepared for that, like, going into it. And to no one's fault, but it was not something that, like, my husband and I were ever prepared for it. And so it was difficult to process that, like, why are we doing this again? Like, oh my God. Like, how are we affording this?
Yeah, it can kind of almost set you up for a failure when you're not expecting IVF to work. And we've talked about this before. It's IVF. How can it not work on the first cycle? Right. And so just know that if you are a young person and, you know, 30s, early 40s, and you have got, you know, a devastating diagnosis of this lower AMH number, 20s even, just know that doesn't mean no hope. You still have, or you still can have, given that you're having cycles at least irregularly, you still can have the same age-related chances as your cohort does with a normal AMH. It just may take more cycles.
Yeah.
And that doesn't mean also if you check it and it's low and you haven't tried to conceive yet that you're going to struggle. It doesn't mean at all that you're going to struggle. But it can help you make decisions for the future, whether that be egg freezing, embryo freezing, planning for IVF, starting a family sooner. And I think that's such an important wealth of information to have.
Absolutely. Yeah, the better you can paint the picture, the more clearly that you can see it.
Yeah, and you know, we're measuring quantity, not quality.
Yeah.
So if you have a low AMH, that doesn't mean that your eggs are bad. You know, it does mean making sure that you have a game plan with the provider, with the right protocols if you're doing IVF. And again, it doesn't mean no chance. And also a caveat to that, you know, if you've been denied at another clinic because your AMH is too low, we do not turn patients away. And I think, you know, if you get anything from this, and I say this all the time, if you're listening to this, schedule an appointment and get your AMH checked. Like, that, I feel like, is so important.
Yeah, at least you have that baseline to be able to you know, make some decisions off of, or not. Like, you know, okay, cool. I feel like I'm good. I'm good with not addressing this again for a year and seeing what happens next year.
Oh yeah, and it's funny because everyone, when they start working here, I know I did, was like, wait, let me go check my AMH. And so everybody here is so well versed on their own reproductive health because we're around it all the time, and we see patients get,
Makes you hyper aware.
Yeah, these devastating diagnoses, and it's like, how unfair that we could have checked this so many years ago, and I didn't know about it.
Right.
So even though it's not within the guidelines, I'm a big proponent of get it checked and then get proper counseling on what that means.
Absolutely.
Anything else you think you want to add?
And then just as always, like any kind of, any kind of emotional grief that you're dealing with, whether it is from a diagnosis of, diminished ovarian reserve, or, you've recently gotten your AMH checked and it's lower than you expected or anticipated. And, you're, just dealing with fertility issues in general. I think that like finding a therapist that understands the fertility space is especially good and healthy to be able to help navigate. And we do have people kind of sporadically throughout the country that we work with that we can recommend to you, or I would recommend finding like support groups in your area, or like virtual support groups that can help you to be able to navigate the next steps.
Yeah, for sure. A good support system is huge.
Or just to listen to you scream sometimes, because sometimes that's what we need.
Yeah. So, yeah, it's not hopeless by any means. Yeah. And hopefully, if you're sitting out there with a lower AMH and you were kind of feeling defeated, hopefully this helps you to know that, it's not impossible. It may take a little longer than somebody in your cohort, but don't lose hope.
Yeah, absolutely. And we're here for you.
Yes. All right. Well, I think that about wraps it up for this episode, and hopefully it was helpful, and we will see you guys next week.
See you next Tuesday.